I think we'll start. I wanted to thank everybody for coming today, to setting your time to join us in this discussion. As Kai pointed out, we have 19 time zones between the two furthest speakers. So we are literally covering the globe here in today's discussion. Today was not meant to be digital or virtual. Today was meant to be an in-person meetup in London at the City offices. And it was going to be a way to welcome Dean, who was going to be visiting London, and a way for him to meet all the lab directors in London. And this is something that we never, when we put this together, which was way before we were talking about COVID-19, we never thought that we'd have to convert this to become a virtual meeting, which is very, very ironic given the topic of discussion. But with the COVID-19 coming up, it's become even more relevant for us to be discussing digitization and how we need to modernize our practice in terms of data collection, in terms of data processing, in terms of automation, in terms of how we are looking at our semen, how we are looking at our embryos, our eggs, and how we are learning through the processes and putting all of this together and learning collectively. So today we're going to be having 4 talks. We have Dean Morbeck, who was our guest of honor, who unfortunately is not here in person, but very, very much virtually. He will be sharing with us about digital technologies to enhance quality control. I'm going to share with you the work that City has been doing around the blockchain. We have Kai. Kai is going to be talking about the future of cryostorage in the 21st century from the work at Tomorrow Life Sciences. And we also have Sean, who's going to be talking about how we use artificial intelligence for semen assessment and how we're modernizing on that side. I feel that we talk about so much about artificial intelligence on the embryo side. It'll be good to see what the sperm is doing in the meantime as well. So I hope you enjoyed the talks. Dean is our first speaker. Not that he needs an introduction, but Dean Morbeck is the Scientific Director of Fertility Associates, which is the leading group of clinics in New Zealand. And Dean, welcome, and over to you.
Okay. Great, thanks, Christina. Be here. Thanks for the invite, and I really am bummed that I'm not there. Although at this very moment, I'm happy to be in New Zealand. I wish I could say the backdrop was exactly where I'm at, but it's not too far away, and we're very grateful and fortunate to be where we are here. So, have you shared my screen? I'm all set. Okay, good. So Chris gave me this wonderful title, Digital Technologies and Enhanced Quality Control. We all do quality control all the time, so this is not a foreign concept. It's something that we do as we start the day. So what I like to do is relate a lot of what we do in the lab to the airline industry. So let's see if I can make my slides move. There we go. Here's something that none of us are really seeing anymore. Maybe we're dreaming about doing this again. One of my colleagues this morning, he flew to one of the other clinics for the first time in New Zealand today. And I told him I was a little jealous because I feel like I've had my wings clipped. But I like to use the airline industry as a really good analogy for what we do. The airline industry is fantastic at getting people safely to their destination. And our job as embryologists, lab directors, and so on, is getting gametes and embryos safely to their destination. Now, of course, we don't know what that destination is, unlike in the airline industry, because many of what we work with are not viable, are not going to end up as a baby. But we do have to get them safely to their destination. It's our job in the lab to make sure we don't get in the way, that we don't, for whatever reason, cause something not to get to where it's meant to go. It's a very simple concept. I think is really easy to rally around, and particularly when we look at why we do quality control and why we want to enhance that. So if we look just at the airline industry, just to talk about the difference between quality control and quality assurance and kind of get some of these terms out of the way. They use a checklist. This is pretty simple. When you start a flight, there's a pre-flight checklist. That's just like when we're starting our day. We have a pre-start of the day checklist. We go through and do all our QC, and we make sure everything's working properly. That's quality control. That's equipment that we're making sure is working properly. And you can do that with the checklist, and you can do that routinely right off the start. In contrast, quality assurance is looking after the fact and looking at how did you perform. You want to assure that you actually did well. And this is a big difference between these two. Is quality control, when you look at the title, means that we actually control something, and we can control equipment, but we can't control people. We can try to, but we end up, with, and we definitely can try to control biology, but we all know that we aren't able to completely control biology, and thus we look after the fact and say, how did we do, and can we talk about quality assurance? So that's here, just from a daily airline performance dashboard, that's a quality assurance point. So I'd like to introduce a new term, because we have all these different terms. We keep going around with quality management and QA and QC, but today I want to talk about dynamic QC, or dynamic quality control. Dynamic QC is the idea that you kind of have an integration of QA in a way that is so responsive that you're almost able to control. At least, control is for us embryologists that like to control things, it's a bit sexier, a bit more appealing term. And we want to be able to do that dynamically. So can we use other metrics, like quality assurance metrics, in a control process? So look at this, and then just look at the overall construct of this. We see that we have quality management as a general term, and which involves QC and QA. But we can see that we've got equipment monitoring, we've got performance, we apply, track, and we have our patient factors, or KPIs, which would be historically that's quality assurance. And all of these are what I'd like to talk about today. There's more than this in our whole construct of quality management, but for the purposes of today, I'm going to just address these and in the concept of digital quality control, as well as digital QA. But the whole idea is we should be digitizing what we're doing. We have so much data that we work with. We can't use it well if we don't have it digitized. So one of the first examples as we start up the day is to use an app to actually start keeping track of the things we do on a daily basis. And I like this screenshot from the website for Reflections, the app that does a daily QC, and the idea that you ditch the clipboard. The whole concept here is we want to be able to not write on paper, not have something that isn't traceable, trackable, easily reviewable. Let's put it on electronic digitized process, and then be able to use that to our benefit and to the system's benefit. And Giles Palmer has done a nice job with this paper that came out last year, where they looked at 36 different labs, and we're able to show the variation in how we do these things. But the concept here, and this is just a screenshot from our New Zealand lab where we were trialing this out, is that we have all of our different components within the lab, and we can get this information on a daily basis, which allows us to then over time to see how are the pieces of equipment, what's the quality control doing over time, and have that digitized. So this is kind of like the next iteration of beyond our analog, paper-based system, and now we're talking, we want to be able to digitize it. What we do currently, let's digitize it. The next step beyond that is to say, well, once a day to do QC is great, but shouldn't we really have it 24/7? And I'd list here some of the companies that do 24/7 monitoring. There's likely more. I just took a sampling. The idea is that we really want to know what's going on all the time. We want to know what's going on in the middle of the night with our incubators. Now, we all have 24/7 alarm monitoring, but we don't necessarily all have 24/7 ability to see what's the temperature and the CO2 and O2 and so on throughout the 24 hours of a day. And that's really the next step we go. And of course, I'd love this as well. And I don't know how many of you have it, but it's one of these components that I think is in our future if we don't have it now. One of the things when we look at the different types of equipment we have, we've evolved to where our incubators now are really high tech. And you look at the early days using desiccator jars to now having, you know, time-lapse incubators that provide 24/7 ability to get even like the functioning of the machine out of it in a real-time manner is really quite a bit of powerful data. So that's 24/7 monitoring of equipment. Of course, within our labs, we have one piece of equipment which is a little bit archaic or unique, and that, of course, is our embryo storage, our cryo storage. And this is a picture from an article from Pomeroy and Marcone. Brent Hazelrig on this call. These pictures are from him, I see. And this is from 2018. And I'd like to, I don't like to, but unfortunately, 2018 is a year that I will mark as always the year that cryo storage became front and center for our field, where we realized that, okay, we have to do something different about this. And that the old way of doing things isn't good. It's not safe enough. We need to be, you know, introducing newer technologies to do a better job of tracking what we're doing. And of course, you'll be hearing later today from Kai Bregman about this system. This is one of the images. I know they are in continuous development, so whether this is even what it looks like now as the robot evolves, and whether this statement that one robot replaces 15 or 20 doers, whether that's the case, the idea is that you have a advanced technology to really make sure our cryo samples are safe. So going back to my analogy to the airline industry, this is a key thing. We have to get the samples safely to their destination. In this case, it's storage over time. It's also when we ship samples. You know, it's another perfect example that we have to get them safely to their destination. So this is, you know, a big development for our field that 2018 really ushered in that change. Now, this slide shows this would replace 15 to 20 doers. I can tell you that it's going to be a while before my clinics here or in Malaysia, you know, there's 9 clinics. They're of all different sizes. They have all different settings as far as what the physical plant looks like and whether we can have liquid nitrogen access to the machine. It's going to take a while for us to be able to use this. So we need we need a better solution now. So we've been working on one in New Zealand. Actually, if Bert Stewart's in the audience, hi Bert. As Bert Stewart started this project 15 years ago here in New Zealand with this little company called Atrax. And I say it's little because it's just this little place in New Zealand, but they provide the majority of weighing solutions and dimensioning for the world's airports. You can see those little dots for Atrax. They're all over the world in all the airports. And it turns out they're just right down the road from where we are here in Auckland. And Bert started this project 15 years ago. The technology around wireless was not as capable then. And so in 2018, after the big events occurred, I went back to them, and they've now developed a cryo storage system for doers. And so you see there on the right is the wireless monitor for the tanks. And here's just a picture from our andrology lab showing you some of the what we call little R2D2s, where they've got stands for the doers. You see a little button here where we basically press that to silence it when it goes into alarm while we're working. But this includes both weight and temperature monitoring 24/7. And so we know that weight will be one of the earliest things that detects a tank failure, and as will temperature. And we have temperature sensors in the base of this, which pick up when there's cooling coming down the sides. So this provides 2 layers of supports, but it's 24/7, and I think that's really valuable for weight because then we can also track how does a tank maintain its insulation and ability to keep the liquid nitrogen levels consistent, or is it starting to fail? And will a smart system of software be able to detect a tank failure that's impending? So this is something that we're still in the development phase. We're doing our validations of the stands, but this gives us some other technology that gives us that 24/7 monitoring. Okay, now let's switch gears to our staff and how they perform. And there's a couple different ways that we could track that from a quality control, quality assurance standpoint. This picture is of two embryologists in Auckland. One is a team leader here. The other one is now in London. We have several London Kiwis from FA who are there. If they're on the call, hello, miss you guys. This is Summer Sorensen, and here's the two of these. They're looking at a borderline embryo and deciding, well, do I freeze this or not? Which is a question we often face as embryologists when we're like, this is a borderline one. I need to get some second opinion on what to do. So how do we control for this? This is a decision that's made that we know as humans is going to vary from person to person. And so how do we make sure that we have this in a consistent and reliable manner? Well, one way is to actually, query people. And we did a survey, which will be in press soon in JARG, which is looking at, would you freeze this embryo given this clinical scenario where they already have all these embryos? And what we've learned is that if they have if they already have a lot of embryos frozen, you probably won't freeze this embryo. But if it's the only embryo they have, then you're more likely to freeze it. And it varies depending on the embryologist. So this is something that we need to control for a bit. One way to do that is with software. And so this is possible through, obviously, a number of different ways. One disclosure I do have in this space is that I am on the advisory board for Art Compass, Carol Kirko's company, where she's got this app. It's really a beautiful app that allows you to do all of these features here. And what it allows also to do is basically query your embryologist to say, making a clinical decision, will you transfer this embryo or thaw another? So that's not a very becoming embryo, but I think if we took a poll of hands here, we might see some variation in whether we would thaw another embryo in this case. And this would allow, it's basically EQA for decision making that's a little different. So gamete expert, other things can introduce this as well, but this is something we do need to control for. Now I put this up there because we need a solution now to make sure we're being as consistent as possible, but I really do hope that, and what will come up probably in the rest of the talk today as well from the other speakers is that there's other ways to do this better than embryologists to make this decision. And hopefully AI or machine learning will allow that. And 2018 was the year of the tank failures. 2019 is the year that machine learning and AI came into our fold. And these three papers came out in 2019. So one from Cornell, one from Australia, and one from Taiwan. And it really ushered in this new era that is why we're actually having this meeting today, because a lot of what we're talking about is machine learning. And this hopefully takes away the uncertainty or the variability that we do know occurs in decision making for certain things in the laboratory. And so that's hopeful. But it's not just decisions that embryologists make that we want to track. It's also how we work. And so we know that there's technology available to track how we work. And we track because we're doing e-witnessing, because we want to make sure that the witnessing of each step is done correctly. But it also allows us to track the timings of events today. And that is more data to feed into our quality control, our dynamic quality control system. And so these are just two of the papers that have been published using, say, IVF Witness. And what I'll just show is that, not wanting to show anything specific about this table other than that it's very granular. There's a ton of data here that when you think about what we do every day, if you're not using a e-witness system, there's a lot of things going on that you could be capturing like this that then allow you to analyze and see, do they impact outcomes? Are they varying among the staff? A lot of different things that we can use to control for that. But as you can imagine, I keep talking about all these different things, and it's like, well, how the heck do we pull it all together? Well, first, the last of those four areas I wanted to talk about was quality assurance, and really the importance of having an electronic medical record. So if our data for our patients isn't digitized, then we really have a hard time doing much. We use Meditex here in New Zealand. We got it right when I got here in 2016, which I was thrilled by because I'd been using an access system at Mayo Clinic when I was there for a dozen years that allowed me to do a lot of data analysis that I didn't have before when I was working from spreadsheets. And so with Meditex, it allows us to do a ton of data analysis and really capture a lot of what's going on. That's critical. It allowed us to publish this paper where we were tracking our blastocyst rates when we made a media change. And the idea is that we want to be able to see how our patient metrics are functioning over time and respond quickly if something goes off. So this graph is from, it shows you day 5 usable blastocyst rates for one clinics. It shows you historically the media change that we published in that paper last year. So this is our day 5 rate and just the control chart, standard control chart with the lower limits. We saw a shift here, and what occurred during this time was we know there was a complete revamp of our clinical space, and we also saw a slightly lower pregnancy rate, but we definitely saw an impact on our day 5 blastocyst rate. So it seemed like there was a quality issue going on there, and we did everything we could to buffer against that, and it wasn't enough. And then we had one more recently in June of 2019, where you see something like this, it drops, you're like, oh, what happened? Okay, let me go back, let's see what things changed. If you know me well, you know I'm pretty keen on looking at mineral oil or paraffin oil as one of my main research areas. And that's the first thing that we change a lot of oil, but then I have to look at everything that we have because it wasn't that. And we never found what changed, and we saw it came right back. It could just be variation, we don't know. But what I believe is that if we could incorporate all of this into a machine learning process, that we could actually detect what's going on with a responsive dashboard system, as opposed to the manual method of saying, I see a shift, now let me go back and look at our lot numbers, let me see who did what. Many different things that you have to check anytime you see a shift in your system. And so, of course, the control of our products is really important. Keeping track of them, again, is something that we don't all have good systems for. So both the Reflections app and the Art Compass have this as part of their process to actually put in the lot numbers. Meditex has as well. It's the slickest yet, and so we're still hoping that do better. But we need to be able to track the lot numbers digitally so that we can feed that into a system. And thus, all of these things, when combined, would deliver on this dynamic quality control, which I put under the heading of using machine learning or artificial intelligence, which is much easier to say AI always, but dynamic QC, where we've got the EMR patient factors included, the procedural timings, the supply chain tracking, the 24/7 equipment monitoring, all of these pulled together into one machine learning process can then alert us to when there's deviations in the control system, to then alert us to say, there's something wrong, you need to do something. So with that, I will end with a picture actually from Minnesota, and provide my email if anybody wants to contact me, and I'm happy to take any questions.
Thank you so much, Dean. That was a great talk. Yeah, I should have given you quality control and quality assurance, but it's not as catchy a title.
It isn't, I agree.
Does anybody have any questions? The beauty of having this format of webinar is that you can ask questions directly. So if you want to ask a question, all you need to do is unmute and start speaking. While you're thinking of a question, I thought I put one for you, Dean. I loved your R2D2s. I think the name is catchy, but I wanted to understand a little bit. Does it help with your early detection? The fact that you're measuring the weight of the tanks compared to just the temperature. Is this something you looked at?
Yeah, so we I didn't put the picture in there, but we have one tank where we've got a valve on the vacuum port, and so we can actually we've been validating this with a tank that we can change the speed of the leak in the vacuum and the speed of the liquid nitrogen evaporation. And we're not the first to show it. Actually, Phil Matson, I think, was the first to show it in Western Australia now almost 10 years ago, where he showed that speed or that weight-based sensing for dewars is actually quite sensitive. And we know that there's problems with internal probes, depending on the placement, that they don't necessarily give an early indication of a change. So the two things that we found, because we did internal temperature compared to external temperature compared to the weight, and the weight and the external temperature were the indicators of an imminent tank failure, of an actual tank occurring. And I need to clarify, R2D2 is just a little nickname we have for it. We probably have a copyright thing that we'll not be able to actually use that. And it's also not something that we're doing. So that's Atrax's product, and they're working with potential distributors for how to get that out to the world.
Okay. Do you have any other questions from the audience? And if not, we're going to have a discussion towards the end. So I'll just swiftly move on to my screen, if that's okay. Okay, can you guys all see the screen? Excellent. Okay, so I'm going to talk about a different aspect of digitization in IVF. And this talk now is going to be about the blockchain in IVF. So full disclosure, I am a consultant clinical embryologist. I am the managing director of embryology internationally for Tomorrow. I work very closely with Kai, who's going to be talking about that project. I am a lecturer at Imperial College London, and I am the CSO of Apricity, which I will be talking about today. But this aspect of the project is non-profit, it's open source, and it's about providing a road of collaboration. So why did we start this project? Well, healthcare data is incredibly sensitive. And for that reason, it requires standards for data processing. We need to respect the fact that the data that we have on the embryos, on the sperm, on the eggs, on the patients, this data requires privacy and confidentiality to respect the needs from the patient. So if it's identifiable information, we have a whole set of regulation that's in place to ensure that that privacy and confidentiality is met. We also need to respect traceability and transparency. So all the interactions with local data should be tracked. We need to know what's happening whenever somebody is accessing this very sensitive information regarding our patients. We need to know what data was accessed, when, by whom, and for what purpose at all times. And the responsibility of this lies with the clinic. We need to have accountability in order. So the data controller, which is the clinic, has to fully control who accesses this data at all times. And security must be in place to make sure that no unauthorized access is even possible. And all of these are done within the context of ethics. So it's not just about maintaining the data safe and secure, but it's also whoever does have access to it, whoever is granted access to it, is going to use the data for the right purposes and with the correct consequences. So what we have at the moment around healthcare data, there's a whole blanket that protects it, which is around these 5 principles. So how do we learn from clinical data? And this slide is purposefully complex to show that it's a bit of a journey. So if we go to step 1, the moment that the patient has their treatment, we have to get their consent, step 2, or you move on to step 3 when the data is collected for clinical decision making, and then step 4 when the data is organized, processed, stored, and protected. And the duty for this green part of the roadmap is kept by the clinic. But then comes the point where a researcher has a curiosity and wants to ask a question that will hopefully enhance the standards of care for patients going forward. So the researcher asks to this question, but in order to be able to target the question onto the data, they, in some countries, will require regulatory approval, which is step 6. They might require specific ethics approval for specific projects. They might require research permissions specific to the center who's holding the research. And then finally, when they've gone through all those steps, they start conducting the research. They start collecting the data, analyzing the data, then they publish it. Then it gets appraised by the general professionals and key opinion leaders of the field. And only then do we start considering having the learnings from this data applied in clinical practice. But to go from step 1 to step 10 can take months, if not years. So what I'm thinking about here is, how is there a way that we can streamline the research process while still preserving the key standards regarding the safety of the data, regarding the ethics of the data, regarding all those 5 steps, privacy, confidentiality, and making sure that all those are still protected? And in fact, COVID-19 has brought an environment that has made this possible, or has brought the need for this to become reality. This was published in The Economist. The pandemic has spawned a new way to study medical records. And they are talking at precisely this, how instead of taking months or years, within 42 days, they have gone from an idea to publication. And it's this change in how data is processed and how research is conducted in terms of access and permissions. It's this change that is bringing the questions that we're talking about today. It has allowed for a very fast response in a COVID-19 pandemic. So that's a little bit on why we would want to streamline the research process. But what about that first step, from the moment the patient has treatment to before the researcher has the question, that part inside the clinic, streamlining the data capture and streamlining that processing? How do we do it today, and can we streamline that so that we can speed up the progress of knowledge within the field of fertility? So the HFA National Registry is what we call a centralized data system. It fulfills the regulatory needs. It's been designed for that purpose, and it allows the regulator to check that the clinics are performing to the standards of care that they should be performing in order to provide the service to the patients. We have spent a lot of time analyzing the data in the HFEA National Registry to see what can be learned from it. We have submitted an abstract that will be presented at the ESHRE conference in 2020, which will also be virtual. And we kind of discussed, what is it that we can learn from the 1 million cycles that we have in the UK registry data set? And we have several examples in there where, despite the size of the data set, despite the fact that you have 1 million cycles of data, when we're looking at specific cohorts, we start getting insufficient data points to conclude on the best clinical practice. In other examples, we have missing data types, for instance, more details on the embryo quality, whether the patient experienced OHSS or not, the clinical and laboratory practices in individual places, which might have an impact in terms of the question you're trying to answer. And we also had inaccuracies, particularly in the area of the type of infertility. And this is because we need to revisit not only the way that the data is brought together, but also the way that the data is collected. And in this case, to try and streamline the inaccuracies. So let's go through just one of these examples. So we wanted to ask the question, which we presented this at the Fertility 2020 in January, which was presented in Edinburgh. And the question was, what is the impact of the number of fresh eggs collected on treatment outcome? So if you look at the number of eggs collected according to each age group, you see here a frequency distribution of where they lie. What you can see is that in green you have, I've got sufficient data to start answering this question, and the red section is, well, we don't have enough data. What you see is that the older the patient, or the larger the number of eggs, we start getting to the area where I actually can't answer the question in this particular phenotype. So if she's 40 years old and she's got 26 eggs, I have no idea whether we should be pushing this patient more or not. So to answer the simple question, the impact of number of fresh eggs collected on treatment outcome, we can only do that for a certain group of patients. But if we start asking, but now I want to know within each subgroup of the quality of the embryo, we no longer have enough data in any of the cohorts if we start breaking it down to the imagery of that particular embryo. So once if we want to be able to answer these questions, we need more than 1 million data points. To get more than that, we need to go beyond the country. And now many countries around the world have their own centralized data. And what would be a nice solution would be if we could bring it all together into one big data pool. But this is not realistic, this is not possible, and the legality of most of these countries wouldn't permit such an exercise. So we need a different solution. The consequence that we have in the IVF sector by handling limited data in our research projects when we're doing cohort studies is that it leads to contradicting research. And this contradictive research leads to inconclusive metadata, which eventually leads to differences in practice around the world with patients of similar characteristics. And this is what we're trying to change. These inconsistencies in care standards need to be ironed out. And also we need a space to validate in a safe way the new technologies that are coming forward. So Dean mentioned all the technologies associated with identifying which embryo we should be transferring back or not. Deep learning is going to bring a lot of data-based tools into clinical practice, and they're only going to be able to be useful if we're able to validate them. So Bill Gates is a big fan of artificial intelligence, but he believes that it's not just about bringing AI into the world, it's about how do we bring AI into the world in an ethical manner? How do we make it accessible, not just for the rich patients, but for all patients? And we're hoping that this is how we can help. AI is clearly an emerging topic in the field of fertility. And we have another abstract that we'll be presenting at ESHRI, where we have analyzed the past 2 years of what's been happening with the publications and presentations at ASRM, ESHRI, and the Fertility Conference, which is the main conference in the UK. And we can clearly see that the interest in the topic is increasing. ESHRI this year has several sections who are focused entirely on deep learning. But the quality of the projects that we're putting forward is not great. We are handling insufficient sample sizes, and they're not diverse enough for us to be able to make the tools that we need to make for the patients going forward, not in a safe manner anyway. And for deep learning standards, it needs more data if we want to improve clinical application. We also need to think about the fact that the data presented on AI at the conferences in the last 2 to 3 years have all had very varied efficacy levels. And this goes to all the abstracts. They all lacked, even when you included the presentation, even when you included the publications that came in papers afterwards, they lacked sufficient details on the algorithm structure to allow for suitable scrutiny as to the validity of the claims being put forward. So these 3 things need to be resolved. But the problem is the way that we're centralizing this data is hindering. So AI progress in IVF is hindered by the ineffective cohort studies, which have insufficient, poor quality, and biased data sets. The solution is not a centralized pool of data from around the world. So we've covered that is just not going to be possible. So we can use technology instead to do a decentralized data hub without a central authority. This is what we call a democratized data hub. The beauty of this system is that data never leaves the control of the clinic. The clinic holds the data and physically has the data under their control, which is where the data should always be. What travels from clinic to clinic are the algorithms. The algorithms go into the clinic, They learn from the clinic. They then move on to the next clinic, and they become smarter and smarter as they go from one clinic to the next, until eventually they come back, not with the data, but just the metadata sufficient to be able to determine whether this AI tool works or doesn't work. Is it time to have it clinically available? In order to make this comply with the standards of how healthcare data should be handled, it's built around blockchain. Now, blockchain improves data transactions in 5 easy steps. I'm just going to try and break it down so that us embryologists can understand it. Researcher A requests access to data from clinic B. That's the first step. You make a request for access to data. This request is then recorded as a block. Next thing that happens is that the network verifies and manages a transaction through a cluster of computers. So all these computers, all these servers that are in this blockchain network, each of them is going to verify that this is correct. And this is what makes it so secure, because it's not possible for us to go around and fake with every single one of these computers. They all are working simultaneously together. The next step, if the security is granted, it goes through the hyperledger technology, and this ensures that the access is permitted. So predefined permissions are kind of put forward, and what then happens is that B receives a transaction request from clinic A. It's gone through all those checks, it's gone through all of this information, and each of these steps, step 1, step 2, step 3, has created blocks which are intertwined. And each of these blocks are records which are completely immutable. Once they are created, they cannot be changed. And this is what creates the traceability. You know at all times who requested data from who, when was the access permitted, or was the access not granted? And this provides the accountability within this network. So lastly, this isn't an interaction from one person to the next. This is an interaction of many people to many people. And this creates unlimited transactions, which hopefully will bring unlimited progress. So this is what blockchain is in very simple terms. So what Apricity has done is that they brought together this decentralized structure with the blockchain. And the hope is that we can then obtain more and better quality data, not just for a single entity, but all the clinics working collaboratively around the world. The framework is designed for collaborative fertility data science projects. So it's specific for fertility. And it's designed to facilitate secure data sharing between the clinics to make sure that it's safe, secure, ensure it's traceable and accountable, that it guarantees confidentiality and privacy, and that information governance and regulatory aspects are fully compliant. It reduces the cost of innovation and validation of implementation. So rather than organizing $1 million RCTs, we can validate all these tools for embryo selection using this system in a much more cost-effective manner. And the hope is that if we can make more cost-effective validation, we can now not only make it safer for implementation, but hopefully reduce the cost of IVF over time, making IVF more accessible. It enhances evidence-based medicine as well. So the hope is that we can then bring more consistency and improve the standards of care through collaborative research. The projects that we're doing can be broken down into 4 aspects. The first one is that at university level, we're trying to provide the skills for the future generation of embryologists. So we are teaching them about coding. We're teaching them about AI. Because in the future, there's going to be 2 types of embryologists in the world. The ones who tell AI what to do, and the ones who follow what AI tells them to do. And we want to prepare the next generation to have more and more embryologists who are capable to tell AI what to do. Secondly, we are hoping to help clinics, and this is helping the current generation. So how can we help the clinics, the current embryologists, understand AI? How can we help them be part of the AI evolution that's coming to all of us? We are helping the AI developers, the many AI companies from around the world, to try and create an easier path to bring their brilliant ideas into clinical practice. And lastly, we're also in talks with some country-wide regulators to try and figure out if there are ways that this can be used to enhance the regulatory process as well. So to support clinics, we do this using modern methods for automated data capture and processing. And there's a journey for AI. A lot of people come to me and they say, Christina, we want you to help us come into the AI journey. And then when I come to the clinic, the whole clinic is paper-based. So the very first step we need to think of is you need to figure out how to digitize all your information. And this is partly why we're having this seminar today. So how you collect your data, you should become paper phobic. You need to get to the point where everything is digitized so that you can learn from your data faster, so that no information is lost that could be useful for yourself or for your patients. You then go into data validation and processing, you go into, and once you get to that point, you're then able to start building your AI algorithms and trying to determine how they can, whether they work or not. The testing is a whole other aspect. And what we're seeing today is that people who are building AI are testing on what the data they have access to, which is limited. And we want to see it starting with single clinic data, moving on to multiple clinics, and then getting to the point where the algorithms get accreditation, get deployed, and then there's the ongoing validation, ensuring that the algorithm is maintained and updated over time. We also want to support researchers at the clinics to understand how to visualize their data and how to validate their data. And when they get this point, we want to get them to understand how to create deep learning tools, so that only then can they be part and understand how to reap the benefits that come from AI: increased consistency, reduced risk and error, increased efficacy, or increased efficiency as well. Efficiency is twice because it's very important. And then you have the support of AI researchers on validating the deep learning tools, because we need to step away from the pyramid of evidence-based medicine, which is completely designed around intervention. And we need to better understand what is really the best way that we should be assessing prognostic tools, not just AI, but time-lapse, PGT, or any other tool that we're using to determine a prediction of whether this embryo is going to lead to a baby or not, whether this patient is going to become pregnant or not, whether she's going to miscarry or not. Any of these prognostic tools are going to have a slightly different route than an intervention. And the prognostic AI tools are going to have slightly different vocabulary. It's not an exposure, it's input. It's not an outcome, it's output. We don't go through a cross-sectional study. You do training and validation, which then goes on to a blind test, a true blind test, a multi-center blind test, until eventually we have a large-scale cohort study, which we're hoping to get to the point where we don't have just thousands of images of embryos, but millions if we start connecting at the global level, which is where it should be. We want to support AI developers to incorporate their AI-based tools into clinical practice to benefit not only patients, but the IVF professionals as well. We have put together this is not from Apricity, this is me personally, but we kind of organized, and I've spoken to a lot of my colleagues, and we've come together to put together a consensus on the standards for data sharing. And this is going to be happening at ESHRE, where we're hoping that in the context of these new technologies that are coming today around blockchain, we need some specific standards which are for the IVF field, so that we can better understand how to move forward with these technologies. So the Apricity Data Hub has a long journey ahead to kind of bring this into full fruition. So I'm hoping that the Data Hub will be the baseline technology for data-driven technologies in fertility to evolve. It's kind of like a playground for AI to promote multi-center collaborative work, not just at the national level, but at an international level, and to properly build and validate new AI algorithms before they're used clinically, reducing the cost of data-driven technologies. There's three main areas that I want to see an improvement in terms of efficiency, so that we can tackle the accessibility to treatment. In terms of the patient experience, I want to see patients more empowered by the information that comes from their treatment. And also about consistency in practice. And hopefully when we get all this together, we can increase the success rates to patients. I want to thank the amazing team at Apricity, and in particular, Jerome Chambos, Celine Jacques, and Chris Alexandri-Pena, who have made the Apricity Data Hub a reality. So thank you very much. So it's always awkward chairing the session that you're talking. And so I'm just wondering if there are any questions. Okay, so what we'll do for now is we'll move on to Kai's talk. Kai is going to be talking now about the Tomorrow, which is a fantastic project. And Kai is a colleague of mine in Tomorrow, and he's responsible for launching and growing Tomorrow's European and international operations. He brings this amazing experience that comes from California Cryobank, where he was the chief financial officer there. And he left that so that he could become the founder of IVF Cryo. And through IVF Cryo, he became an advisor to clinics all over the world in order to help them increase the standards of their cryo storage to get to the point where the biorepository grade cryo storage level. So there's clearly a need, as we saw from Dean's talk, there's clearly a need for us to improve how we're storing our embryos. And Tomorrow we'll hopefully be able to help the field with that. So Kai, over to you.
Thank you, Christina. Can we see my screen?
Yeah, it's in presenter mode. Do you have a way to make it full screen?
Yes. Let me switch. Hold on a sec. I think I have to move it. It's still in presenter mode.
We're not sharing now, so it's not showing now.
Okay. Hold on a sec.
In the meantime, while you set that one up, I might ask Dean a few questions.
Sure.
So, Dean, you mentioned about the troubleshooting software concept, being able to predict when you're going to have an issue, or not predict when you have an issue, but the fact that you've gone outside the threshold.
Tobias.
There you go.
Thank you.
Yeah. So when you are just outside the threshold of normality, and I'm just thinking about your thoughts in terms of how do you see quality control data being used to not just tell us how to react when you're outside, but are there examples where we can predict when it's going to happen before it goes outside the threshold? Are there ways that we can prevent non-conformities you can think of? Not just now, but in the future.
Right. I mean, that's the goal. You would hope that that's possible. Of course, with any of the machine learning we're doing, we have to provide as solid of a definite answer to the machine to say, this is an example of where it's not working and how it can learn that. And so that's the big challenge to get to, is how do we actually train the system to detect these kinds of shifts? And that's, speaks to your data and your talk about blockchain is we need a lot of data. First, we really need to become digitized to be able to have it all and start to say, okay, now we saw a dip in pregnancy rates or a decrease in whatever. And we can say that was definitely a change that we feel was important. Now, take all the other information and start tying it together, which is beyond our mind's ability to do.
Yeah, because it will certainly help in terms of the troubleshooting, isn't it? When going forward.
It'd be great to be able to, forecast it. I mean, I think mostly it's early detection, though.
Okay, I think what we might do, Sean, would you be able to share your screen, and I'll help Kai in the background. I know. Oh, maybe Kai's working now.
This guy's browser.
Oh, that worked. Okay, we'll go ahead with Kai's talk. Kai, let me unmute you. There you go.
The trouble of having two screens and the Zoom at the same time. Good morning, everyone. It's still morning here. We all know that embryologists have superpowers. That's nothing new, but even superheroes have their weaknesses. The kryptonite in IVF is the cryogenic specimen management. As Dean mentioned, 2018 was one of those watershed moments when that really came to be very visible that we have issues. So how do we reduce or even eliminate the impact of this kryptonite? Technology can be a blessing and a curse. People love technology, people hate technology, and it rarely leaves someone indifferent. It can bring great breakthroughs for humanity, or it can leapfrog ethics and societal norms. Dramatic events often are the catalysts for technological advancements. In our field, science and technology have made great advances in the laboratory, but not so much in other areas, creating an imbalance. Technology is great when it's applied to areas where humans are not so good at, when it's well understood by the users, both in what you can do with it and what its limitations are. Great technology can also relieve its users from a great deal of stress. As many of you learned on Friday from the IVF Initiative webinar on what stresses out embryologists, fear of making errors is a great stressor in IVF. If technology can take away that fear, if we can eliminate errors, we have succeeded. But first, let's look at what can happen when technology not only fails, but allows humans to make mistakes. And then we'll look what are the technologies that can help embryologists to enhance their superpowers. Now, Dean used Boeing as an example of a good thing. I bring up the other side, before you even start doing pre-flight checks, you develop an airplane. Seems like a long time ago now with everything that has happened since then, but serves as a perfect example of what can go wrong when technology falls behind the current needs. There were three fundamental problems that likely led to the two catastrophic incidents: using an old system design that can no longer meet the modern requirements, having to spend extra for fixes for problems that should not be there in the first place, and not recognizing what appropriate training consists of. These three fundamental problems are the same in the IVF world, and that likely led to the catastrophic failures in 2018, and could have easily have happened elsewhere in the world, and may have actually happened. IVF clinics were not starting with the idea of storing reproductive tissue long-term. First, it was all fresh, then some were frozen and eventually vitrified and used later, then some were left over, then some more, and were stored explicitly for future use at some unknown date, years from now. It's a whole new ball game now. It made sense in the beginning. Use small, easily maneuverable tanks to store specimens within the laboratory and have the embryologists manage them on the side. It wasn't worth even creating policies and procedures for, let alone new technology for that. It was short-term. It wasn't that big or significant. Any embryologist could handle that, no additional training required. It started growing. More of those small, easily maneuverable milk jugs were added until every under-the-counter nook and cranny were filled with them. Maybe even a broom closet was cleared to house them, at least partially cleared. I've seen those. When the old system cannot be modified enough to meet the current requirements, you need to reimagine the whole system and all of its elements. You need a new airplane, not an iteration of an old plane. It's easy to keep buying these small doers and not think about them, and embryologists can get that approved quickly. But to reimagine the whole system, who's got time for that? That's not what a radiologist was trained for, and not what a clinician was trained for. And it's not what they were meant to be doing. So today I'll cover 4 critical areas of technology that will help the other side get on par with the advances in the laboratory. I will talk about data management, specimen identification, specimen handling, and the integration of technologies within the laboratory. I will also highlight some areas where these technologies can help us beyond just your laboratory. And how do we eliminate tasks that your brain is not well equipped to do? How do we amplify the physical and cognitive ergonomics that help your brain with other tasks? Data management couldn't be further from the core functions from an IVF clinic, and yet it couldn't be more critical for the clinic and their patients. Impact the clinic in multiple ways. Is your data secure from intrusion? Is your data safe and available if you lost your clinic to a fire, flood, hurricane? Is the integrity of your data ensured? Has someone protected your Excel spreadsheets to make sure that no one can accidentally sort one column and not the other, or accidentally delete a bunch of rows? Is your data efficient? In other words, do you have to enter the same data in multiple places? Do you have to access multiple physical or digital data sources to have the complete information of your patient or the specimen history? These are key questions when evaluating your data management. Let's take data security briefly. Forget HIPAA, forget 21 CFR Part 11, forget GDPR. This is how complex your data security preparation should be. But it would be very hard for an individual clinic to perform this kind of security review, let alone all the shortcomings. But data security is a weakness that IVF has to solve, both within one clinic, but increasingly so between the clinic and other clinics, offsite storage facilities, testing laboratories, sometimes across countries or continents. At Tomorrow, where the largest group of talented employees work in software development, we have built our system to meet the requirements of HITRUST, which is a global certification system that exceeds all the requirements of HIPAA, GDPR, or the various ISO standards combined. We have built that into our software so that no clinic would have to worry about it or spend their limited resources into trying to address those limitations. We had to address that so that all the other innovations could be applied to reinventing the IVF clinic's specimen management. Beyond the foundational data security issues, we also had to address the other 2 data challenges, integrity and efficiency. We had to make sure that our system seamlessly connects with the existing systems in the laboratories and helps clinics eliminate the manual records or spreadsheet records. No duplicate data, no manual logs, no Excel spreadsheets. So that's critical in terms of data management. Humans are poor in multitasking. Our short-term memory is not well equipped for multitasking. We have limited working memory. Witnessing and double witnessing is the worst kind of interruption for your limited working memory. Our brain, over millions of years, has highly developed pattern recognition capabilities for movement and visual patterns. Our brain is well trained to figure out the clues in movement and visual feedback and to fill the gaps when we have incomplete feedback. This is not good for reading and confirming a serial number, date of birth, or a name, which is what witnessing or triple witnessing is all about, especially when you were focusing on something else just moments before. Instead, we have developed technologies and tools that amplify what we do. Barcode readers have answered some of those challenges, but not all, leaving plenty of room for forgetfulness, errors, and inability to read frosty, torn, or ill-applied labels on tiny devices. We need to eliminate the task that your brain is not well equipped to do. Enter RFID tags. First, we envisioned a system that eliminates the task that we should not be doing in the first place. A system using RFID throughout the process, not just in one stage of the process. Starting with the straw, the device, we have worked with manufacturers to embed our RFID into the straw itself. So the moment that an embryo or an egg comes off the microscope on the straw, the same straw that you have used before, it's now equipped with RFID. our software will instantly recognize and register it. For the first time, you have an identity management system at the specimen level. Second innovation is our cryobeacon. There are millions of specimens already stored in dewars throughout the world. It would not solve the problem simply by fixing it going forward. We need to take care of the legacy inventory. Cryobeacon is our reimagined goblet that allows the clinic to move all the current specimens to be part of the RFID-enabled system. A straw goes into the beacon, and it establishes a digital link between the straw and the beacon, which cannot be broken. And the beacon is linked to an individual patient. So all the specimens for an individual patient go into the beacon, and the link between those straws and the beacon cannot be broken. So we're safeguarding specimen identification mix-up from the first moment. Eliminating human specimen identification was a critical problem to solve, but there was more. As everyone in this Zoom room knows, handling specimens is an equally critical problem to solve. We humans are better at these ergonomics, but not great. Too much opportunity still left for us to make errors because we're stressed out, distracted, or just plain clumsy. We need to amplify the physical and cognitive ergonomics of our brain and eliminate some processes that expose the specimens to hostile environments like ambient temperature. Here's what we have developed for that. The one thing we heard again and again from the dozens of embryologists who we spoke to and who were involved in the development of our system is that there really has never been an adequate purpose-built or even sufficient way to move specimens within the lab. I've seen so many solutions that are unsafe, ergonomic. So we spend a lot of time and resources developing the first cryotransporter specifically designed for a fertility lab. This is the ultimate portable, closed-lid cryogenic environment for moving specimens within the lab, and it provides the highest level of protection against any innocent exposure. And it's one of the instances where you see that we have used NASA-derived technology, literally technology that has been to Mars or protected sensitive equipment tens of millions of miles away in the most adverse condition. It maintains specimens in liquid nitrogen at -196 Celsius for very long periods of time. And it's designed for use in both vitrification and warming workflows. Again, not just for a transporter, but because we designed it hand in glove with the leading embryologists, it's designed to fit in the workflow and aid in the workflow. The cryograde, some have heard the word cassette, but our latest naming convention called the cryograde. It's a key element imagined specimen flow with completely new materials. One of the quotes we have from the early years, Barry Bear, and he's very funny, at Stanford, he calls it the magic box. Each cryograde organizes and protects the specimens as they enter and inhabit and exit the cryorobot. So this is the grid in which specimens are organized. And of course, it's engineered with the space-age high-performance materials that we talked about. This cryograde in normal operations would never be exposed to ambient temperatures for more than 30 seconds or so. But typical of the kind of over-engineering we've done, the kind of extraordinary attention to safety which the team has taken, we designed it to maintain safe cryogenic temperatures within the grade for up to 4 to 5 minutes in ambient temperature. So this prime example, just one example, our approach to over-engineering for safety through. And here, and Dean, yes, it has developed a little bit since you last saw it. Our big shiny object that most of you have already seen in its first iteration. Of course, a familiar story by now is the cryogrid is embedded with the RFID technology. As it enters or leaves the robot, we track and verify the identity of the specimen through a console, which is attached to the robot itself now. We spend a lot of time working with embryologists to design an ergonomic workstation, an ergonomic console, which is embedded with the RFID technology. So as specimens are entering or leaving the robot, they are again checked here by the Tomorrow system using RFID to remove any risk of confusion regarding specimen identity. If you choose the wrong specimen, you are alerted immediately and cannot proceed in the operation until that is corrected. So this whole system is unparalleled levels of safety and transparency. workflow as samples enter and exit storage using the RFID verification. Now, the cryo robot itself, it's something that we are obviously very proud of, but we built this on the shoulders of giants. The core technology here, the robotic technology, is something that was pioneered by our partners at Brooks Life Sciences, which is a big public American company. They pioneered the work with the National Institutes of Health and Kite Pharma and others in advanced medicine, progressive medicine, for whom cryopreservation and cryomanagement is at the core of what they do. They like it at the core, just like it is at the core of what we do at IVF. If you're involved in cell therapy, you need to get this right every time. It must be right every time, and it must be completely dependable. The core technology of what we're done with the robot is this background and experience proven over a decade with automated storage and retrieval. We have heavily modified the realities and the needs of IVF. I think that's clear in our discussions of our work over the last 2 years with the embryologists. And originally, and Dean mentioned this also, we were talking to our partners about this technology. We were so involved in the novel inventions that we glossed over the fact that there is indeed maybe 80% reduction in terms of the real estate needed to store the specimens using this kind of robotic system, which is obviously critical issue for many clinics. I mentioned earlier that our software team is the single largest group at Tomorrow, and the Tomorrow software is, like Mina Alekani pointed out earlier in some conversations, that the ultimate form of sophistication is simplicity. Couldn't agree with her more. That was the mandate from our founders to our team. This has got to be an ATM simple or Apple simple. I live in an Apple home, and one of the glories of Apple, of course, is that something comes out of the box and it just works and it integrates with everything else. You don't have to have many manuals. I don't think they even exist. The system is designed to work intuitively and to function beautifully straight out of the box. We worked hard to do just that with this system. Everything is intuitive with software-guided touchscreen, so we're providing guidance for the embryologist every step of the way. It truly is as easy as using an ATM. We provide a full audit trail of all activities associated with the specimen. You have 100% QC history, to Dean's delight. All of the environmental conditions, the lab interaction, anything that might have affected the health and well-being of the specimen, whether it's for a day or whether it's for a decade, doesn't matter. We have complete transparency through our work in this system. Of course, automatically identify location and position of all embryos and gametes in the robot. That is the key principle and what it's all about. Complete confidence in the inventory at a moment's notice. No more manual inventories. The system provides instant touch of a button inventory for every sample in your collection. Touch of a button, and whether you have 800 or 8,000 specimens in the collection, you can review the inventory any day without touching them or pulling them out of the drawer. And then, so we've covered technology within the laboratory, but we also realize that IVF clinics are increasingly part of a larger network of clinics, or really have to transfer the older specimens with no immediate indication for use to offsite storage. We have designed the system for that as well, using the same RFID technology, same space diagram, and the next generation real-time tracking. Now ship gametes and embryos to and from your clinic and have instant access and complete record of its movement and conditions while in transport. The fourth area to cover is the who is that? Paul Newman from Cool Hand Luke. Integration of all these technologies is critical to provide a real solution for IVF clinics. They need to communicate with each other. If we look at all the technologies I've just covered in this presentation, you can see how they fit in the workflow of an IVF clinic. What we haven't discussed is how we help the clinics to have full oversight of the complete system. We call it the Overwatch. We saw in earlier slides how we designed the system to meet the toughest data security requirements with high trust. This enables build an outside layer to monitor the systems at every clinic. In addition to the clinic itself having full access to all of the data we track on the system, we also have deployed machine learning and predictive analysis to help alert the clinics and us to any potential issues that could happen in the future. Dozens of integrated sensors all over the machine drive predictive analytics to discover issues well before they become problems. You know, in our view, and in the view of many of our colleagues in modern medicine, if alarms are going off with the equipment, we already have a design failure. The whole point of modern technology and modern predictive analytics is that we are watching the smallest variance from the norm over long periods of time, every second of the day, to discover issues long before they become problems. And we learn from hundreds of other systems, not just the ones at your clinic. That's at the core of what we do. So that's what we have developed. 4 key areas, 7 innovations. But our core technology applied much more broadly than just for the management of the gametes and embryos within a clinic, between clinics, or at a biorepository. We are in active discussions with many technology providers and plastic manufacturers to create a unified system throughout the entire fertility ecosystem. If the identification and collection of data is RFID enabled, with a globally unique identification system for patients and specimens, we could reassure our patients of the safety and unbroken chain of custody from patient identification to specimen acquisition, processing, storage, and transportation. You could send your biopsies to testing laboratories and still keep an unbroken link to your specimens. And going beyond that, using blockchain that Christina was talking about, you could connect all of the information of the patient and specimen history to the specimen, giving the patient complete access and complete control as access to that information. That's our vision, and we're working hard to make it reality soon. Thank you. Over to you, Christina.
Thank you very much, Kai. That's very inspirational. Do we have any questions from anyone? I was just wondering if you could clarify. I think for many people in the audience who won't have seen the Tomorrow platform before, can you clarify? Does this exist? It might seem sci-fi to some people, something futuristic. Does this exist? Is it here now? Are people using this?
It is more than CGI. The original system was developed over a year and a half ago, and it's been in active use at our partner clinics in the United States, at 4 major clinics throughout the country. We're getting ready to launch commercial cost in the United States and early 2021, hopefully in Europe, once we have our CE markings ready. So it is real, it's being launched, it's being used, coming to your clinic soon.
Yeah, I can see it completely revolutionizing the way that we're doing our cryo storage at the moment. So Sean, I think it's you next. Now that we've covered the quality control, the blockchain, we've covered the cryo storage, it's time to talk about the sperm.
Pleased to meet Chris. Okay, lovely. So I'd like to say thank you for volunteering me to present my thoughts today. You did promise me wine, so I'm going to have to hold you to that once lockdown is over. And it's always a difficult gig trying to sell the concept of applying CASA or looking and thinking about semen analysis to a bunch of embryologists in a meeting. So I've got to say a bigger thank you to the previous speakers who's made my job far, far, far easier. So today I'm here to talk about automation and artificial intelligence to enhance semen analysis and semen assessments. I'm a laboratory manager in a clinic in London. So hopefully we can have a thought and a discussion about considering semen analysis, automating that activity, and using artificial intelligence in our laboratories. We should be considering the application of CASA, and we can discuss whether there is a benefit of applying a computerized system to an activity that's normally performed by an embryologist or an andrologist. Looking at how a CASA system is designed from scratch is a great way of showing how artificial intelligence is applied and the technology is developed. And hopefully we can have a little bit of a chat at the end and discuss the potential of sperm-related automation. So my disclaimer is that I have been interacting with a CASA production company that uses AI and machine learning as the backbone of its processes. I have another disclaimer as well. I wasn't really interested. I wasn't really bought into the thought of AI and machine learning. I was just after a CASA system. I wanted to find a computer-aided system that will able to see kinetic parameters and see the difference between kinetic parameters while performing research work. But when engaging with this company, I was exposed to the concept of artificial intelligence and machine learning. And when you think about the potential of applying such processes to any part of our ART activity, the ability to be able to take data, to analyze that data, and then to help assist decision making in a standardized manner is absolutely amazing. So the concept of applying the analysis of an image, being able to review that and give a standardized picture of that, or a picture of a number of images, is the same as taking diagnostic information from a patient and giving a standardized outcome or standardized direction for treatment. Now, we all know that not all machines are good, and it's difficult to apply those to ART activities. And it's a general thing that we're all has a little bit of a concern about AI and machine learning, and the thought of that machine taking over our roles and performing our activities. So engaging with implementing artificial intelligence in something as performing semen analysis dragged me out of the darkness and into the light of the potential for AI. So semen analysis has been going on for a long time, hundreds and hundreds of years, developed during the first steps of developing microscopy. But we have not really developed our potential for employing automation to all of our activities, and especially semen analyses. And this picture is of a modern pathology laboratory, and you can see that automation is now a standard activity, whereas we'd have individuals assessing a microbiology agar plate, or aliquoting serum into a number of reagent containers. Now this is all automated, and when you consider where pathology is and where conception is, you've got to think that we need to move on and need to work towards a different future. Oops. And ignoring technological advances is not really a concept. Embryologists need to have to engage in this situation to be able to drive the narrative and affect the quality of future devices, and be engaged in the development of these devices to help them to be an assistant. And that flows back into to the particular company's mindset of using AI in every part of a patient's journey, and even AI can be involved in additional activities. I mean, in the future, I'm sure that we'll be placing gametes into conceits, possibly using microfluidics to help handle oocytes, to select sperm, to prepare sperm, and maybe even in the future, automation will be performing inseminations with automatic ICSI and automatic IVF. We already have automation with our time-lapse systems in our laboratory. So we go back that sort of, no, a human isn't a human better than a machine. No, we shouldn't be embracing AI. But we know that from looking at the World Health Organization manual and the World Health Organization rules and regulations, that the gold standard is a human to perform the semen analysis. But even though we have these guidance to drive our gold standards, are we all compliant in our laboratories? And we must be aware that humans are imperfect, and imprecision in semen analysis is a common feature. We know of intra and interassay variabilities, and that's been described in the literature very widely. We do have a problem of having a standardized report, a standardized result, if we have different operators performing an analysis. So why not use I wanted a CASA machine, I wanted a CASA system, I wanted to be able to check kinetic parameters. Why not use a standard CASA machine? Well, the use of segmented image analysis doesn't always enable us to be able to perform an assessment as we would like. And we all know about the difficulty it has been for CASA companies to adopt their technologies in our laboratories and our reticence to them. And that's usually because the ability to recognize and acquire a sperm track, or recognize a sperm per se for a concentration determination or motility assessment hasn't been as we would like it to be. So, what's the difference with artificial intelligence? Why should we be thinking about adopting AI? And the key point is that we train the machine. We train the machine to be an assistant. There's always a thought that artificial intelligence is all powerful thing. The tool can learn anything. But really, we need AI to have defined rules, clearly defined inputs. It's difficult when applying it to sperm function and sperm analysis, because the expected outcome is producing a result where it's easier to make an assessment of an embryo and have live birth as the outcome. But we can apply strict rules in terms of measurement and strict rules in terms of identifying an image, and then get an outcome of recognizing those items. So we can achieve very reproducible data if we have clean input of data to recognize the item. Then when we're actually performing a semen analysis, if we control the sample preparation, the protocol that we put together to ensure that the artificial item, the machine, is able to capture the data in exactly the same way as a human has done, and we can then test that data that we get out of the machine using our external quality assurance systems, then we know we're onto a winner. So as a first step is controlling the data input. And if it's a good AI company that's developing an item, they'll spend some time in the laboratory with the embryologist and develop its robotics and equipment to be able to perform an analysis the way that a human would do, and enhance that analysis to ensure that there's an additional number of assessments that can be made. So if you're assessing a number of sperm on a slide, be able to assess far further areas in that slide than a human would. This is the Mojo team spend some time in my laboratory assessing samples and doing analyses. And that's all part and parcel of that deep learning process. And it's a deep learning circle. So you've got to gather information, collect a lot of sample videos, make sure that you train the machine to be able to identify individual items, then annotate those items so that assign a value to an item. So is a sperm, isn't a sperm, is a round cell, has acquired a track. And you go through the process of tagging items and then apply the assessment of the sample of the item to a neural network. If the training process has been performed as you would expect, you can reassess that data, check those annotations, and then see if the AI results are similar to the comparison to a human in a clinical setting, and assess whether the data that you achieve falls in line with your expected outcomes. And if not, you have to go back around the circle again, starting again, gathering data, training, and so forth. So in the first step, you need to get the artificial intelligence to recognize and classify sperm. You need to assess those sperms in all the orientations, whether the focal planes are as you would expect or not, whether the sample has round cells, whether there's debris, unexpected objects. And that's also another criticism of traditional parser systems, that its ability to be able to identify individual sperm or track the sperm trajectory was compromised when the sample had additional elements in or debris. So once you've taught the machine to know, and I suppose I'm a machine trainer now. So once we taught the machine to identify the difference between a sperm or not a sperm, then you can apply the data that you've generated to a convolutional neural network. So that's putting an image through a series of filters. Oops, sorry. A series of filters to reduce the interference of the background, get that background noise down to the minimum, perform that a number of times to then have some connected layers that can be assessed in the next point. Then once the image is very clear, then the neural network will compute the probability of the item that has been observed to be the item that you've indicated. So you've got a sperm, you pass it through a number of image filters. The filters will then visualize the item that you looked at. You've trained it to tell the neural network that that item is a sperm. The filters are applied to identify the object even further, and then the probability is calculated of the item that is observed is actually a sperm, not a sperm. And this shows that concept clearer. So you have an individual item, it's assessed through a number of filters, the image is pulled together, and then a review of those images by a committee is performed to see if it fulfills the criteria that you've trained the item to recognize. So once you've performed the same once you've performed that activity for identifying sperm to be able to perform a semen analysis in terms of getting the sperm concentration, then you can move on to looking at the movements of that cell and measure the track and the trajectory. Once you've performed the training technique, You can then fine tune it to take into account occlusions, that's sperm crossing each other. There's a loss of focus, or the sperm moves in and out of focus, and if that sperm cell moves in and out of a frame. And this is where I am. I'm probably around the third round of the deep learning cycle, and I'm giving some input in assessing sperm, looking at whether they're progressive or not progressive, and checking that in terms of the movement characteristics. Once we have performed a number of analyses and performed a number of annotations, we can apply this assessment of moving cells to a number of algorithms and compare them to manual measurements to see which algorithm fits best at providing an accurate description of sperm movement. Then it's absolutely essential to perform a clinical comparison. So to assess the computer's ability to reproduce, and the human is the gold standard at the moment, reproduce the analysis and the results that we achieve in our standard procedures and our standard protocols. And this has been performed, and would have been performed in my laboratory if it hadn't been for the COVID pandemic. Some data that was published and presented earlier on this year, showing that there's a very, very good correlation of the results that are obtained in terms of sperm concentration between the machine and a manual assessment. And when you look at the problematic area, that's the historically problematic area for cars and machines, and that's identifying sperm with a low concentration. There's a very, very tight ability to be able to reproduce that kind of assessment. So that's really, really, really reassuring. So the results in a laboratory called the Doctors Laboratory in London showed that there was a correct evaluation of analysis in those low sperm concentration group in the majority of those samples that were assessed, and the error rates and statistical significance gave a lot of reassurance. Not so much reassurance that you could stop there, and that's my involvement to take those assessments and go through those further rounds of the developmental process. Another issue that I was supposed to be looking at, and unfortunately hasn't been able to, but will be soon hopefully, is that then taking on an assessment of the ability to validate and maintain the system. So performing clinical comparisons, again assessing it with the machine's performance, and then using pre-prepared slides to assess the machine's ability to assess a calibration type size. So the pre-prepared slide will have beads to test the machine and assess its ability to reproduce the analysis and come up with the same results. So these are the points that we need to consider moving forward. If we were to look at a CASA system with learning capabilities, is that able to perform a reproducible assay? So I think that it's clear to me that we can achieve that if we put the sufficient activity, sufficient efforts in to annotating the sperm in the first instance, and being thoroughly involved in the machine learning process. We know that if you modify the system, if you perform an assessment of how a human does an analysis, performs an analysis, you can ensure that the CASA system is able to analyze more cells than a human operator. And if we can optimize the machine learning process and the machine training process, we can ensure that accuracy can be maintained and increased precision, which we know standardization of a human's ability to reproduce an analysis is. So adopting CASA in our laboratories, it will be the first step towards automation. If we are able to achieve this well, who knows where the future will end. Automation will enable us to perform better sperm selection. If we are able to apply machine learning technologies to use more in-depth microscopy, we could use confocal microscopy, we could use IMSI technology, which we find very difficult as a human to employ, and especially in a semen analysis, which is performed rapidly. So thank you for your attention, and thank you for the Mojo team that provided a lot of the images here in the presentation I've just made.
Thank you so much, Sean. That was a great presentation. It's very interesting what Mojo are doing there with using AI for semen assessment, and also the involvement from yourself and your team in this in this very interesting project. I have a few questions from the audience to all the speakers. They're coming in through the chat. So the first one is for you, Sean, and it's on what are your views on automation, and what are the views from if you could elaborate on that, or if anybody in the audience could elaborate on that, from NIQUAS or from HFEA with regards to automation and AI coming into the fertility field. What do you think? What have you heard?
Well, I think the first thing that an automated CASA system will have to is show that it's able to achieve a comparable result when applying the external quality control systems to them. So we've got to be able to match the machine's ability to be able to perform an analysis in a similar way to a human, and then satisfy the human operator that the NIQUAS results, or the gametes expert results, or the other EQA system are as expected. I would assume it'd be nice to have input from the HFEA that, or another regulator, that would therefore be acceptable. At the moment, CASA systems have not achieved the right validation to be able to be accepted widely across the world as the means of performing a semen analysis. I know that there's work in the UK to enable CASA systems to be recognised as equivalent to a human, and to fulfil the criteria to be able to be considered as performing an assessment to the gold standard.
Rachel, if you want to unmute.
Hi.
Hi. Thank you for coming.
I would echo what Sean's just said. Obviously, from a HFEA point of view, we just need to know that you've validated it properly and it's going to give the accurate results. And if you can prove that, then that's great. Unfortunately, I think the validation of CASA hasn't been great in the past, but if that can be changed and you can provide that evidence, I'm sure the HFEA inspectors would be quite satisfied with that.
We have another follow-up question from Gadeya. Do you want to ask it live? Do you have a microphone? No, maybe not. So here's one from Gabriela. Yes, go ahead.
I saw the question. It is possible to be able to apply the images within a neural network from a static photograph. I mean, that would, I would assume, I'd need some input from the Mojo guys, but I would assume that would be far more straightforward than looking at a trajectory of the sperm, with the sperm head rotating along its axes. A static image would be able to be applied.
Another one for you, Sean.
Sorry, I can chime in there. So I'm Daniel from the Mojo team. So it's entirely possible, and there are several teams. I've seen a lot of research of people applying AI standard microscopes. This would allow you to use the microscopes that you have available in your clinic, capture images or videos yourselves. The problem comes in that AI, as Sean was presenting, is not this all-powerful system. It really needs a very clearly defined input. As soon as you enter into the mix a person manually manipulating a microscope, it makes the equation vastly more difficult. So I think that there may be a future where this could be possible. But at the moment, when you talk about automation, you really need to automate all aspects.
Thank you very much, Daniel. I have another question from Bernardo from Brazil. Do you want to ask it out live, or would you like me to read it out for you? Okay, so Bernardo's question follows very nicely from what Daniel was commenting. So his question was regarding the blockchain. So he wanted to know, how can we trust the information that other clinics from around the world putting into the blockchain is accurate and correct? And you're perfectly right. That is one of the biggest challenges of the project. We have solved one problem, which is how do you move the information from one place to the other in a way that is regulatory compliant and in a way that respects the rights of the patient whose data is derived from. But the other big challenge is in how do you ensure that the data is accurate? And there's two ways that we're tackling this. The first one is with technology. So for instance, we're very keen on things like the presentations that have happened here today. If we can automate the capture of the information using these new technologies coming in, whether it's Tomorrow, whether it is Mojo, whether it is any of the other systems, EmbryoScope is another good example. The time lapses, the reason why we're having so much AI coming out of embryo selection at the moment is because time-lapse has become so widespread. It's something like 1 in 5 clinics in the world now are using some form of time-lapse in their clinic. And this means that we now have standardized the collection of the data of how an image is captured of the embryo. If we can extend that standardization to other aspects of the process, then this is when the trust on the data coming in is going to be much higher. For now, we're keeping things simple. It's not all singing and all dancing data. We're going with data that can be trusted, can be managed, and can be useful in terms of bringing, in the short term, useful tools to both IVF professionals and patients. But this is the big question, and that is what we spend most of our time on, training clinics on the digital aspects and treating their data with the same care and respect that they treat their patients. So we got, does anybody else have any more questions? We got a few more coming in.
Sean.
Yeah, go for it.
Sean, on the sperm side, the analysis challenge, of course, is always that you're looking at a sample. In embryos and eggs, you look at a specific specimen. With the sperm, you look at a sampling of a larger cohort or specimens where the sample preparation becomes an issue. How do you make sure that you standardize on the sample preparation before anything is even put under the microscope?
I mean, the first instance, we need to follow the guidance that have been provided by the Health Organization in terms of liquefaction. And thereafter, then, standardization sample preparation is a little bit of an issue. And the Mojo team are thinking about, and I think it's a really good idea to make slides with the predefined depths, with cover slips that are firmed upon the on the chamber, and that will then allow some kind of standardization in the sample preparation, as long as liquefaction has occurred as you'd expect. There's always that issue if you have an unliquefied sample, and that's going to that viscosity is going to inhibit the accuracy of the result. But that is life, Jim, as we know it. So we're in that situation, and now if we were to perform an analysis on that sample, it will get a comparable result from as a human. The beauty of using a CASA system to be able to analysis in that situation is at least you'll be able to analyze more fields, be able to look at different areas within that sample frame, and then hopefully the increased numbers, if they're there, will give a statistically robust and sound result. And those initial results we got from TDL showing comparisons with a human and the machine at assessing those samples with a low sperm count give us a little bit of reassurance that even if there isn't a large number of cells, we can get a good result.
That's great. I have one question for all the speakers, and anybody in the audience that would like to comment as well. This week, all of you, if any of you have watched the IVF initiative talk, there was a really good talk by Helen Priddle on Friday, and she presented her data on how 25% of UK embryologists are stressed or have mental health issues which are directly caused by work. And this compares to about 14% in the general in other industries. And they referred to things like lack of understanding of what's the work that's required, working under a lot of time having to work with strict time pressures, the fear of being responsible for an error, and long hours without any breaks, and so on. Clearly some issue of understaffing here playing a role there as well. How do you see the technologies that you have discussed? How do you see this helping, not just with regards to efficiency, consistency, the usual that we hear from AI, but how do you see it improving the work environment of the embryologist? Dean, do you want to go first?
I think
I'll just start with we all have our startup process at the beginning of the day, which is actually, it's maybe somewhat therapeutic, but also just an added stress if you're running late. And so to have a 24/7 monitoring system for QC that you have faith in and actually can see a dashboard where you can just glance at the dashboard, just like, Command Central for NASA or something, and that everything's in order, that's peace of mind. So that could potentially take one other of those, stressors away. I mean, it's a small one, but it's something.
Mm.
I think with
go ahead, Sean. I think the overriding theme is using technology where you can supplement the embryologist's normal. Embryologists have been asked to do so many things beyond the actual embryology, whether it's QC or cryogenic specimen management or all kinds of things that to take them away from the actual their actual role and their education. So I think if we can eliminate as many of those side issues from the work, that would most likely improve their lives quite a bit.
I think if we can employ an automated system for semen analysis, I think we'll have a similar reassurance or body reassurance that we have when we were employing time-lapse incubators and embryo assessment. It is a great stress to have to make decisions on an embryo to freeze or an embryo to transfer, to give patient information in an isolated situation. So if you've got these technologies at hand, you can perform an analysis, you can perform a judgment call, and you can call in quite easily a colleague to give reassurance, to give advice, and to have a second check. So the inbuilt algorithms help give staff reassurance on embryo selection, or help highlight staff when they make a judgment call, and that could be put into question. And then if you've got a non-paper based recording system, and you've got images taken of the sperm, the egg, or the embryo, then you can call a colleague to have a look and to give their opinion, and then have someone make a decision with you. Not the most ideal situation, not the greatest stress reliever, but I think it's a great amount of reassurance that will help make our lives a damn sight easier.
Like Dean said in the beginning, ditch the clipboards. You have so much manual work still in so many laboratories that if you continue doing that, the witnessing that I've seen in so many laboratories, when you pull someone out from doing what they're supposed to be doing, just to take a look at a chart or label or some such thing, the constant interruption, I think is a big part of that stress that they experience.
Yeah, that, what you said, Sean, as well, Kai, is around decisional fatigue and just interruptions. So making a decision when you have to suddenly ask someone else for an opinion, that just takes more time. It's kind of an interruption. It's uncertainty that you experience. And then clearly on electronic witnessing, taking the disruptions out of the manual witnessing, that's all going to help as well. So I think many of these are ideally going to make it better.
Yeah, it's been interesting to see over time how when we first started talking about automation and AI in early 2019, late 2018, the first reaction was, I'm going to become unemployed, this is going to replace me, this is going, but the feeling has completely shifted now. And it's really interesting to see the embracement of these technologies and the recognition of how this is going to make our life easier, our life better, reduce our stress levels, make us capable of treating more patients in a short amount of time. We have another question from Hermes Gadede. Would you like to ask a question? I have to unmute, so just one moment. Did that work?
Can you hear me?
Yes, we can.
Fantastic. So first of all, thank you very much, everybody, for the wonderful talks. I have a question to Sean. I'm a mathematician in Bristol, and I've been working for the past, 15 years on sperm analysis, but going beyond the data. So basically use mathematical models to try to understand how the flagella beats, and then try to understand how the trajectories you see under the microscope actually takes place. And often, of course, we work with large amounts of data. We try to use AI, image segmentation, you name it, track the flagellum head in 2D, in 3D, the whole lot. But when it comes to actually how do we use this information, the clinical side, there is always a lot of problem. And with colleagues across different clinics, the same problem often happens, which is if you have a patient that is undergoing, of course, the fertility treatment, they of course have to do some kind of semen analysis. But at the end of this process, regardless of what it is, most of the time, 90% of the time, people will still choose to exit. So and the phrase that I got from all these meetings and trying to convince embryologists, oh no, I don't care about sperm because I will exit. And I feel with you because of course we would like to use the knowledge about sperm in a better way. So my question is mostly, what would be your answer, to this current scenario? Because this is what is happening now. Nobody really cares about semen analysis, and even if you come with the grand, let's say, in my case, the grand theory that shows, oh, this sperm is actually, because it's not clear what you're looking for in sperm in 55 million of cells. So my question is, how do you see the AI and in these very, let's say, it's difficult environment
Yeah.
for sperm analysis, not embryo analysis. The whole different shift in when you talk about embryo analysis, but trying to convince people that sperm analysis is important nowadays is very difficult.
Well, we're at the starting point, Hermes. So if we were to employ robust training processes in identifying what the best sperm is, who knows where we're going to be in the future. With increased automation and increased use of this technology, we could be using confocal microscope or higher magnification of a sample and identify where there are issues that would lead towards performing ICSI, or if we were to have microfluidic systems that help select sperm, if we used hyaluron, for example, to identify the percent capacitating cells and then wash them and then use them for an IVF insemination, we'd be able to reassurance that we are making an analysis with set features that will identify a positive as opposed to a negative that would suggest that ICSI is just performed. So as a stressor, making a decision, a snap decision on whether a sample is good or not, and being worried about the potential for failed fertilization, if you are able to have the reassurance of an assessment that allowed you to be confident that that sperm has the, or that population of sperm have the ability to give you good levels of fertilization with IVF, you've got an argument against those who would say, okay, let's just go straight for ICSI. No, I do. There's lots of unknowns there with performing ICSI. We know ICSI is relatively safe, shall we say, and it's a procedure that's helped many. Natural is best. I think that's an easy thing to say. And if we can perform IVF as opposed to an additional intervention, which has its risks, it's always best to do. So using an automated system and an automated assessment process can lead to us in the future being able to employ those technologies when they're developed to help identify samples where we feel confident, give more confidence performing IVF, and reduce that knee-jerk move towards ICSI due to a fear.
Yeah, good point. You raised an important issue there. And I'd like to first put a plug in for the next international IVF initiative session, not the next one, but one later this week, where we will be talking about ICSI and about, for one, how a performing clinic uses ICSI at a minimum, so at less than 40%. So Hermes, good point. When 80, 90, 100%, how can we possibly even do machine learning for whether a sample will fertilize or not? And so the pendulum needs to swing back. We've since the mid 90s, we've been more and more ICSI for a lot of places. I feel it needs to swing back because ICSI isn't as good as IVF for non-indicated patients. You get fewer embryos, fewer blastocysts. So we need to do less. When we do less, so that's part of it, then we have more ability to then test, train a system to be able to predict for those cases where we might have failed FERT. That's going to be great if we can have better assurance through machine learning that we can, determine which samples might not fertilize. Beyond that is, of course, the viability of the sample. Is there DNA fragmentation? Is there, there's all those things which are principles but need to be proven. If we can show that, then that's going to even give us more evidence and ammunition to say we can use a sample for IVF, or when we do ICSI, we actually can select sperm better. But that needs to be proven.
I have one quick question for you, Dean, before we go. I know we're slightly over the time, but I'm way too curious on the answer. You mentioned in your talk about determining whether an embryo should be frozen or not, and how you take into from your projects and the survey, how you take into consideration how many embryos this particular patient already has, so that the decision is not done on an embryo on its own, but on the patient at the patient level. In terms of determining, let's say if it's the only embryo she's got, what do you think is the percentage viability that you need to hit? What is the threshold that should be reaching for you to determine, yes, this is now an embryo that should be frozen? Because with AI, that's what it's going to be. It's not going to be on looks. It's going to be, it tells me there's 1% chance of becoming a baby. Should I freeze?
Well, so this, I agree. Now, what the big part of what we're leaving out of this whole discussion is the patient and what's the patient preference. And we will need to apply machine learning to the patient preferences as well, and how do we capture that up front? So every patient is different in terms of what their level of risk is in their preferences for that. And what we know that as embryologists, subconsciously, we're making a decision based on all these patient factors that we know exist. We don't have a checklist to say, well, we're going to freeze or not based on this. It's just, well, this one's borderline. Should I freeze it? I don't know. But if it's got any chance of implantation, if that AI result comes back at 0.05, there's still going to be some patients that are going to say that I want to use that embryo, but we don't know which ones. Don't bring the patient into the discussion. They don't even know that we don't know. So that's a big step forward as well, part of this process.
Yeah, he who knows he knows nothing is the wisest, is what they say, isn't it? But that's a very good point. It should always end with the patient, and this is why we're here, is to help the patient. I want to thank everybody for coming. I want to especially thank the speakers. Dean, sorry we couldn't bring you to London, but that'll have to be next time. And Sean, we'll have wine at Upper City at some point, and we'll just have to replicate with different talk. Maybe Hermes, maybe we'll just focus on sperm all day for the next time. Kai, thank you so much for your talk as well. It's very inspirational, the work from tomorrow. It seems so futuristic, and to know that this is here now, to know that we can bring this reduction in risk to our patients is fantastic. So thank you everybody for your time. We will be putting the recording up in ivfmeeting.com, so the IVF initiative. So this will be available recorded if anybody wants to go back and have a look at the information that was discussed here today. If you have any further questions, just drop us an email. I think all of us are findable in LinkedIn or Twitter or internet and so on. So we look forward to continuing these discussions, because digitization is required, it's needed, and we must help it evolve further. Thank you very much, everybody.
Thank you.
All right, thanks, Chris. Yep.